Welcome everyone to the ECG case for the week of March 11th, 2012. Got an interesting case for you once again. This one was sent to us by a paramedic by the name of Tom Bothelet, and I hope I'm pronouncing your name correctly, Tom. If not, I apologize. Tom is a captain and a paramedic in the Hilton Head Fire and Rescue down there in South Carolina, and he loves EKGs. He sent me a handful of really great EKGs before, and for this week's case, he sent me two very nice EKGs. It gives us an opportunity to talk about something that we haven't talked about before, but it's definitely something worth talking about, and I think you're going to start seeing this more and more in the literature, probably in the next coming years, I guess. So Tom had a 68-year-old patient, man or woman, I'm not really sure, but it doesn't really matter. 68-year-old patient who came in with some chest pain and a clearly abnormal EKG. And what you notice on this 12-lead EKG is that there's a bunch of leads that have a little bit of ST segment depression, flip T wave in there, ST segment depression, and all in those precordial leads there's ST segment depression. Let's just go right to those precordial leads, in fact, and focus on them. What you notice is something a little bit unusual, and that's what we're going to talk about. What you notice in a lot of the leads is if you notice where the J point is, there's ST segment depression, the J points are depressed and so on, and then from the J point, the ST depression is rising into a tall, upright T wave, right? So there's ST segment depression that is rising into a tall, upright T wave. And it turns out that that's been described before as highly specific for a critical occlusion in the proximal LAD. Where have you heard before about proximal LAD occlusion? You've heard about it as Wellens syndrome. This is just a little bit different than Wellens syndrome. And just to recap the original article, you'll notice actually that Wellens is the third author on that original article. So Wellens seems to be attracted to proximal LAD occlusions. But there he is again. And these are referred to nowadays by many people as Dewinter T waves because the first author on this article was Dewinter. I don't know what his first name is, but we're just going to call it the Dewinter T waves, and that's what is starting to be referred to as in the literature. In this study, they described in the New England Journal 30 patients that presented to their service with anterior wall MIs, and they had unusual ST segments with T waves. What they described was that these patients had 1 to 3 millimeters of ST segment depression that was upsloping at the J point, primarily present in the precordial leads. The patients also had tall symmetric T waves, just like we saw a moment ago. And a very important point, this was highly specific for acute occlusion of the proximal LAD. Now, let me get rid of some of these marks. In contrast, remember, Wellens is highly specific for proximal LAD critical stenosis as well, but in Wellens, it's not necessarily an acute occlusion with the person having an acute STEMI right now, or an acute MI right now. Wellens is highly concerning for this patient's going to go on in the near future, like in the next 2 to 3 weeks or maybe 2 to 3 days, to have a big anterior wall MI or die. So the difference here is that the Dewinter T waves are more predictive of an acute process, an emergent process. In contrast, Wellens refers a little bit more to a subacute process. So we've said this before, with Wellens syndrome, if there's no ST elevation, just purely Wellens, those patients don't need to go to the cath lab emergently. They probably need to go to the cath lab relatively urgently. Whereas with these Dewinter T waves, it appears that these patients do need to go to the cath lab emergently. Now, let me put a disclaimer in here. This is not currently part of the national guidelines, but more and more people are starting to talk about these Dewinter T waves as essentially a STEMI equivalent. Now, don't call your cardiologist at 1 o'clock in the morning and tell them they've got to come in for this. Talk to them ahead of time and find out what their take on this literature is, because some of them will know about this and be very concerned. Some of them will not have heard about this yet. So talk to them ahead of time. This is another example of Dewinter T waves. This is not present in all of the precordial leads, but Tom sent this also. This patient's actually got a bifascicular block. There's a right bundle branch block and also a left anterior fascicular block. I'm not going to go into detail about the definition of a bifascicular block. What I want to focus your attention on is these precordial leads. Once again, what you see, not so much in V1, but what you see a bit in V2, and then in V3, there's a J point is depressed, and then in V4, J point's depressed, and in V5, J point's depressed, and you've got upsloping ST segment depression shooting right up into a tall, symmetric T wave. Almost looks like what some people might call a hyperacute T wave, except this is even more predictive, apparently, based on the literature that's out there. This patient, by the way, just as an aside, has already infarcted. There's Q waves in V1, V2, V3, and you really shouldn't see those in a right bundle branch block unless the person's already had an anteroseptal MI. So this person's had an anteroseptal MI of uncertain age, and you could probably predict where the occlusion is. Critical occlusion in the proximal LAD because of those Dewinter T waves that we've talked about. Now, if you go back through some of the cases of the week that we've done, back on December 4th, I posted a case of the week that pertained to subtle T-wave abnormalities that predicted cardiac ischemia. And this was one of the cases that I presented, and it was a Dewinter case. I didn't talk about Dewinter T-waves at the time, but I'll talk about it now. And if you went back to December 4th case of the week, you'll see this T-wave abnormality. The Dewinter abnormality will go to the precordial leads once again, and this is a very classic example of the Dewinter T-waves. Once again, you've got J-point depression of anywhere from 1 to 3 millimeters. In a couple of these leads, it's only 1 millimeter, maybe 2 millimeters in lead, maybe even 3 millimeters in lead V2. And then from that ST segment depression, you've got a T wave that shoots straight up and then down. It's almost like hyperkalemia, but the potassiums are normal. And these tall symmetric T waves are highly predictive of that critical occlusion in the proximal LAD. All right, again, ST segment depression, which shoots straight up into a tall symmetric T wave. When you see that, you've got to worry about it. Here is the baseline 12 lead EKG for that case. So it's a huge difference between what he's got now compared to what he had before. Now, this patient, unfortunately, was not treated aggressively, and a short time later went on to have a no-brainer, obvious anterior wall STEMI, and perhaps he could have had a little bit better outcome if he had been treated a little faster. He did survive, but probably lost unnecessary parts of his myocardium as he developed his anterior wall STEMI. So, once again, key point. You're going to hear more and more about this, the Dewinter T waves. And why this is important is because these patients present with ST segment depression instead of elevation. And so normally what we do with ST segment depression, we just treat them with the anti-anginal therapies, heparin, admit them to the unit. But if it turns out that more literature supports this, that this truly is a STEMI equivalent, as it appears to be thus far, then perhaps this is one of those examples of a patient with ST depression who probably needs to go to the cath lab right now instead of waiting. So keep your eyes open for more literature on this. Talk to your cardiologist because, as I mentioned, there are already cardiologists that believe that these Dewinter T-wave patients need to go to the cath lab right now and not sit around and wait. Talk to your cardiologist about it. Send them the literature. Again, this is New England Journal, and there's other articles that have come out talking about this as well. And be on the lookout for these type of patients with ST segment depression. All right, hope that helps with your patient care, and I will talk to you next week. Bye for now.